Once again, I'd like to welcome everybody to our webinar today, which is New Growth, the Essentials of Using Time to Choose E&M Level of Service, Part 1 of Part 2. My name is Leanne Foster, and I am a member of the Provider Outreach and Education team here today. I did mention this is Part 1 of Part 2. This is the first in a two-part series that we are doing on choosing your level of service using time. In April, Ashley and I did a two-part series covering an overview of choosing your level of service. Kind of everything, time, MDM, everything you could use. During those sessions, we did also announce that we're planning future sessions that dig deeper into specific elements for choosing your level of service. And we are kicking that off here today with the first in the two-part series focusing on time. Today we're going to cover the concept of using time, and tomorrow Ashley's going to be leading an interactive session that's going to talk about denials and rejections related to using time, and it also has an interactive activity that's going to provide you the opportunity to apply the knowledge that you've gained today through today's session. Our goal for today's session is to provide you with a better understanding of how to select the appropriate level of service using time spent in the encounter for that patient. It's going to help you choose the appropriate CPT code for the services that are being reported on the claim. So to achieve that today, we're going to be talking about qualifying activities. We received quite a few questions regarding what counts towards time. So today we're going to be covering what activities count and what activities do not count when you're determining the time that you want to use to choose your level of service. We also are going to discuss some documentation expectations. Time is simpler than medical decision making, but we still get questions about what reviewers are looking for when they're looking at provider documentation. And then also we have included some resources in the training material today that are going to help you make that decision. I do also want to point out that we do have some disclaimers at the end of today's session. We are going to be showing you with some CPT codes, which are controlled by the American Medical Association. So if you're interested in those disclaimers, they are included at the end of the presentation today. So we'll start with a brief overview of some core items to keep in mind when you're selecting the appropriate CPT code and billing Medicare. First and foremost is medical necessity. If you have attended other sessions facilitated by Ashley, myself, others on the provider outreach and education team, you've heard this before. You've seen this before. However, this does continue to be something that we see questions on, and it does continue to be something that we do see in our denials, rejections, and our cert errors. So the first determinant of coverage is always going to be whether the service is medically necessary for the patient. Per the Social Security Act of Section 1862, which I've included a link here, services must be reasonable and necessary to treat an illness or injury or to improve the functioning of a malformed body member. So this is all going to be based on your documentation. What did you do to the patient? Why does the patient need the services in this encounter? Are they reasonable? Are they medically necessary? And you need to make sure that they're not statutorily excluded. When MACs review claims, and our medical review areas are looking at that, also when our comprehensive error rate or our CERT contractors are looking at those, they're looking at that documentation to support the medical necessity of that service. That's first and foremost. So it all comes down to that documentation, and you'll hear me refer to that today, even before we get to that section of our presentation today. Along with medical necessity, you also need to consider new versus established patient. A common denial that we see is new patient services being billed when they should be established or vice versa. And you do need to consider this even with time because there are different sets of codes. So you want to consider what new versus established patient means. So what Medicare is looking for is that for a new patient is that the patient hasn't been seen in the previous 3 years by the same physician or a member of that same group with the same specialty. And when we call out specialty, we are talking about the two-digit code that the provider is declaring or designating during their enrollment process. So you just want to make sure that you're considering all of that as you're choosing your level of service. So to start with, the AMA again owns those descriptions of the procedure codes, and it includes the level of service. For most codes, not all, but most codes, you are able to decide which level of or choose your level of service, and you're able to decide whether or not you're going to use time or medical decision making. You do have a choice for most services. Now, we did get a pre-submitted question that was asking if it's appropriate for providers to use time on most patient encounters. And as I said, you have a choice. So the answer is that it's going to vary. It's not going to be the same for every encounter. It's not inappropriate to use time on most encounters, but you're going to want to ask yourself if that is going to be the most beneficial to you. Meaning, it's not always going to be best to use time or MDM. You need to look at it. Part of our goal today is to help you understand time so that when you're comparing the two, you can make the decision that's best for you and the best for your practice. There are going to be some exceptions. Some services are only going to allow you to utilize MDM or time. Examples here include critical care services, which are a time-based code. You would have to use time. The flip side of that is going to be emergency department, where you would need to use medical decision making only. And we'll talk about that a little bit more as we go through, but you have to look to see what is most advantageous for you. We did get another pre-submitted question that fits well here, is asking if the provider documents time, but MDM is more advantageous, can the provider code by MDM? And the answer is, again, you have the choice for most services, so yes. Scenarios happen where you could have a 30-minute office visit, which is going to allow you for a low level of service code. However, MDM may be significantly more complex, and if the documentation supports it, it may allow for a higher level of code. So again, you'll hear this theme a lot. It's going to come down to what happened for the patient and what is most beneficial to you or most advantageous to you. You've done the work, make sure that you're selecting that appropriate level of service. But again, today we are focusing on using time. So flipping back to time specific, ultimately, we are going to be, it's going to be subjective. There's going to be gray areas, and it's going to be up to you and your organization to decide what those standards are going to be or which way you're going to bill. So we'll start by talking through time. The time is identified in the code descriptors, and you're going to see that in the CPT. Make sure you're paying attention to that. They'll tell you whether or not it is something where you have the choice or something where you don't. But when we're looking at time, it's going to say it as you must meet at least X amount of minutes. So it's going to be a matter of meeting that or exceeding that time. It is going to be the cumulative time that was spent on that same calendar date. This can include both face-to-face time and non-face-to-face time. There's going to be times where physician and practitioners want to make sure that they're documenting both of those. There's times where they're documenting the face-to-face time, but maybe not the non-face-to-face time, and that's really actually impacting the level of service and possibly not or undervaluing the code or the service that you can bill. The non-face-to-face time can actually make the difference in the level of service that you're selecting when you're using time. Okay. Now I also want to count out or point out that the time that we're looking at here is the time that's spent by that practitioner. This is not including your ancillary staff. And this is time spent by the practitioner in direct patient care. When you're documenting your time, and we'll talk about this more later, but you're going to need to document specific time. We're not looking for a range here. So if you're providing those face-to-face and non-face-to-face activities, make sure you're accounting for all of that. You'll hear me say this as well. We're not looking for you to stopwatch yourselves or the providers to stopwatch themselves, but it does need to be shown as in the medical record accurately, not arranged. 30 to 60 minutes would be in an appropriate way in order to document that. We need to have that medical record accurately reflect the time that was spent. CMS does actually speak to this in the Medicare Claims Processing Manual, Chapter 12, and I have included a link to this in the resources section for today, but it does call out where it instructs MACs to review for accuracy on the time. And when MACs are reviewing that documentation, it needs to make sense for what is documented as having happened in that encounter. So let's look at the required time thresholds. So there are requirements for the thresholds of time. As I mentioned, when you're using time, you do need to meet or exceed the time that's in that descriptor. You are looking for the total time of services on the date of encounter. So this means that same calendar date. We will get into prolonged care codes later on in the session today. And with that, you might see some variances from that, but it's specific to the service that's being provided. But typically, time, choosing your level of service, it is the date of the encounter, the time spent on that date that we're looking at. And as I've said a couple times here, face-to-face and non-face-to-face. That non-face-to-face time is something that we do see is not always included. Um, and you want to make sure you're paying attention to that descriptor. So here I do have a visual of what the descriptor looks like. In this visual, what you're going to see is the 99212 through 215, and the yellow highlight is actually highlighting what it will look like when the time is called out in that descriptor. If you look at different services that don't allow time, this section, this sentence, this statement, however you want to put that, is not going to be there. So for instance, let's look at 99215. This is the level of service that you would use when 40 minutes is met or exceeded. Now stepping down to the 99214, that has 30 minutes must be met or exceeded. So that would mean if you have 35 minutes, you are still billing 99214, not 99215, because while you've exceeded the 30 minutes, you haven't met the 40 minutes that you must meet to bill that 99215. So there's going to be that little bit, I don't want to call it a gap, but there's going to be that time between the 30 and the 40, those 10 minutes, you're still just billing that 99214. But again, as I called out earlier, this may be a situation where you want to look and see if you can bill with medical decision making. Otherwise, you do have to meet these thresholds. So let's look at the types of qualifying activities that are going to allow you to count for the time. We get a lot of questions about what activities can be counted towards the time. So the face-to-face activities, the things that you're going to be able to count are going to be obtaining or reviewing a separately obtained history. This could be a conversation with a family member if for some reason the patient is unable to provide that. Maybe they have dementia, maybe they're not communicative, but that is going to be something that can be used. It is the exam that's performed for the patient on that day, so it is that encounter. What exam or what test, what happened in that encounter. It can include conversations or counseling that you have with the patient, family member, or caregiver. Again, the circumstances of where these conversations happen is going to vary by patient, but that time can be counted. Typically, obviously, this is the face-to-face time. It can also be if you have conversations with another qualified health practitioner, again, face-to-face as part of that encounter. But non-face-to-face services do count. And so you want to think about preparing to see the patient. If you're spending time doing that before they get there, uh, you want to count that time. Now, I do want to call out date of encounter. So if this is something that is happening a couple of days before the date of encounter, it's not something that's going to count. But if you're doing it just before, that is time that you do want to count when you're determining your level of service. Ordering medications, tests, or procedures, as long as they're being done by the practitioner that is seeing the patient that day, that is time that can be counted. Again, we talked about it earlier about it not being your ancillary staff. So this is going to be time spent by the practitioner ordering medications, tests, or procedures, not their staff. You can also count the time where the practitioner is referring and communicating with other healthcare practitioners. That may happen face-to-face or non-face-to-face. You can count that. One thing, and we'll talk about this, is when it's not separately reported. Okay. You also want to count time documenting clinical information in the medical records, so charting. You want to make sure that you're counting that time, again, if that practitioner is doing it themselves. If there's any independent interpretation of results, not just reviewing results of, say, a test or an x-ray, but independent interpretations, which will have some type of documentation in the report. Does not have to be on the level of, say, a radiologist, but it does have to include the practitioner's findings and their assessment of that, not just I agree with the radiologist. So you want to make sure that that information is in that medical record to substantiate, but you also want to make sure that it's not something that you're billing a professional component for separately, say for a chest x-ray. Just depends on how that service is being billed and how it's incorporated. You can't count that twice. If there's any care coordination that's not being reported separately, that time can be counted. Um, and then also any time that you're spending communicating with maybe community agencies to coordinate care. Maybe you have some services that you're organizing for them, again, as long as the provider is doing that. Things that you're not going to want to count. Don't count time that is spent, that is, one is staff time, we talked about that, but services that are being separately reported, again, we're not counting that time twice. So if there is a CPT code that you're billing for that service, you're not also counting that time in that E&M visit. So if it has a CPT code specific to it, make sure that you're watching that. Travel time, so if you have home services, it's not the travel time going to the patient. You're not counting that time. And then teaching that's general and not specific to the management of the individual patient. We did get a pre-submitted question here. And the question was asking, can time spent discussing the treatment plan with the resident count towards the time for level of service at an E&M? And the answer would be yes, provided it is direct patient care and it's not general education in nature. And that documentation is going to need to support what part of that treatment for that patient, what part of that patient's care it was supporting. So it's a discussion as another qualified health practitioner versus just teaching that's general in nature. One thing I want to call out is we do get questions on total time, and sometimes we probably have all experienced this. You're in your doctor's office and you start talking about things that aren't related to the care. You're talking about the weather. You're talking about a book that you read. Those of us, my counterparts and I, our providers know we work with Medicare. They might ask us questions about things that are happening in the Medicare space. That time does not count. So here I just wanted to give you a little bit of a recap, a little bit of a visual of what is meant by total time. So when you're using time to calculate level of service, you want to make sure you're looking at the entire picture for that date of service. So it's your face-to-face time which we talked about the qualifying activities there. Encounter prep time, again, it has to happen on the day of the visit, not several days before or the day before the visit. It's date of service. And you can also want to add in any after visit time, as long as all of that is being done by that practitioner. Count that practitioner's time. They did the work. So that is going to get you to your total time for the encounter, and ultimately that total time is what you're using to select your level of service. Again, we talked about those descriptors for codes that allow for time to choose your level of service. So now we're going to start getting into some things that are a little bit different from using time to choose your level of service as far as the basics, but they are going to be related, or they're going to impact you when you're choosing your level of service using time. So we're going to start with critical care. So critical care is a time-based code. That means that you can only use time to determine the level of service billed. So you're not going to have your choice here. MDM's not used here. Now, providers do have to ensure that they're documenting all of the time that they've spent on providing critical care services to that patient. Time that they are providing those critical care services has to meet the requirements for critical care services. And you want to count it all because, again, the amount of time spent can impact the number of units. And here I've included the codes that you're going to use. It's going to be 99291 for the first 30 to 74 minutes, and then 99292 for each additional 30 minutes past the 74. So you have to meet the 74 minutes before you can start billing for 292. Now, we're not getting into critical care services in great detail today because that is a course and a webinar all in of itself. However, Ashley and I did do a series on critical care late last year. So if you're looking for more detailed information specific to critical care, then you're going to potentially want to look at those videos. And I've asked Ashley to throw those into the chat for you so you can take a look at those. Next, we're going to talk about ER services. So emergency department services are MDM only. You cannot use time, and there's a lot of reasons for that, but you're using MDM. So that means you have to look at the problems addressed, the data that was analyzed in the care, and the risk. And some of the reasons that time's not used for emergency department is because the care is going to vary in level of intensity. They could be having multiple encounters with that same patient on that one date of service or during that time period. And the provider is likely going to be seeing multiple patients simultaneously, so really keeping track of that time. And AMA have decided that it is extremely difficult. So this is a code that is going to be MDM only, and you cannot use time. So make sure you know what service you're trying to bill so you know whether or not time is even an option for you. So this would impact codes 99281 through 99285. Those are all MDM only codes. Another thing to consider when you're choosing your level of service using time is your ability to bill for prolonged care. The intent here is to ensure providers are compensated for additional time and effort that's dedicated to patient care. Again, prolonged care codes, you have to be using your time to choose your level of service. Prolonged care codes is not something that is going to be available to you if you're using medical decision making. So you're going to have to choose which avenue that is going to be most beneficial to you, and if it's time, prolonged care codes are on the table. You are here also still including all of the face-to-face and non-face-to-face time based on those qualifying activities. I do also want to call out those qualifying activities are in the CPT code if you're looking for, or CPT book, if you're looking for a reference so that you have those. Again, we did get quite a few questions on those, so I want to make sure everyone knows that. The intent here again is to make sure that you're compensated for all time that you're spending on that patient's care. So any additional time that's spent above and beyond the highest level of base E&M code. So we're talking about 205 and 215. So we're looking for that highest level of code. But again, it includes both that face-to-face and non-face-to-face time. One other thing that I do want to point out when you're billing for these codes, our system is going to be looking for that primary code. So as we get into these, we are looking for that 99205 or 215 to be on that same claim. You're not going to bill these prolonged codes on their own after the fact. Our system is going to deny out those codes when they're not finding that primary code, and they're not going to look back in our system for those codes. So make sure that you're billing the prolonged care codes with that primary code. Now, prolonged care codes do have time thresholds that do need to be adhered to. So in order to bill prolonged care codes, you must exceed the time allotted for that highest level of code. And we've mentioned that the 205, that's going to be 60 minutes must be met or exceeded. So for the 205 code, you have to get to 60 minutes before you can start considering the ability to bill for a prolonged code. And for the 215, it's going to be 40 minutes. After that, you can bill multiple units of prolonged codes in 15-minute increments, but you have to meet the entire 15-minute increment. You're also going to need to meet the threshold set by CMS, and we're going to go into that here in just a second. With prolonged care codes, you're probably all aware that CPT does have some codes that are specific for prolonged care. Medicare does not recognize those codes. We do have our own codes, and they're G codes. They are in our Medicare claims processing manual. I'm just going to go to that real quickly. And actually, I'll start from here. If you go to Medicare, if you go to cms.gov, I have the manual pulled up, but I want to show you how to get to that as well. Under Medicare, you can go to Regulations and Guidance, and you're going into Manuals. That's one way to get to it. The other way is if you scroll down from the home page, there is a Manual Forms and Transmittals section, and the Internet-only manuals are there as well. Personal preference, I typically am going through that second method just because it's quicker. And when you are here, you are going to look for the Medicare Claims Processing Manual. And then I mentioned Chapter 12. And here you are going to see prolonged care codes. And it's going to be 30.6.15. This is going to be a very valuable resource when you're looking at prolonged care codes. We do also have this information, or CMS has this information listed in their Evaluation and Management MLN or Medicare Learning Network booklet, and we'll show you that as well. But this is going to show you the time thresholds, and it's going to provide you with some examples, and we're going to talk about that. Here I do have a visual of the Evaluation and Management Services Guide that CMS has, and let me grab that. Sorry, my controls for the webinar are just hiding my tab. But when you're in the Evaluation and Services book, you are going to see a section that is specific to prolonged care. And I'm just going to use the jump here. But you will see the same chart that you have up on that I have up on the presentation for you. So all of these examples are available to you in multiple places. So they're great, again, great resources that you'll want to leverage. So as I said, the threshold is typically 15 minutes, but you do need to meet CMS's thresholds. And so starting with office and outpatient services, you are going to be using G2212. And again, it's only available to you when you are choosing level of service via time and you have met or exceeded the highest level of time for either that 99205 or that 99215. And here you'll see, for instance, 99205, if you have 60 to 74 minutes, you are still just billing that base code. You would not be able to bill for prolonged care until you hit the 89-minute threshold. And I know that's not going to be 15 minutes past the maximum, which is 60, that's 75 minutes. But these are the thresholds that CMS has set, and you do need to hit those thresholds and those ranges in order to bill. Now, for office and outpatient services, when you're counting your time, the time, as I've stated before, does have to be on the same date of service as that primary code. So in this case, that's that 205 or the 215. Now, once you hit the threshold for billing prolonged care codes, you will be able to bill an additional unit for every full 15 minutes. If you look at the third example on the visual that you see 99205 and it's for 104 to 118. They're billing the base code at 1 unit and the G2212 at 2 units. Now, the full 15 minutes. If you have the full 15 minutes, that is a unit of prolonged care code. If you had, say, 25 minutes past the threshold, that is still 1 unit of G2212 because you'd have 15 and then 10. That 10 minutes doesn't meet or exceed. You can't bill that second unit until you meet or exceed that 15-minute threshold. So again, these charts that are in that MLN and the claims processing manual are going to be extremely helpful to you. One additional item that I want to point out with G2212 is that it can be used for cognitive assessment and care planning, and that is listed in that MLN that we just went to. Little bit different rules for counting your time though. Now it can be let me take a step back, but what is included in that cognitive assessment and care planning? You're going to think of things as cognitive focused evaluations. Maybe there is a functional assessment. Maybe you're using some type of standardized instrument. Maybe there's a medication review that's involved in this, or you're doing some advanced care planning for the patient and caregiver needs. Now, all of that can happen on the date of service, but you can also count time here for up to 3 days before. This is a little bit different than what we've been talking about. I've been telling you it's got to be the day of. For cognitive assessment and care planning, there's some latitude there. So up to 3 days before and up to 7 days after, and of course that date of service. So you can count that time. So if you have some services that would be qualifying activities for and fall into cognitive assessment planning, don't necessarily bill right away on the date of service. Make sure you're allowing for all of that time because, as I said, the primary care code, that primary E&M code, needs to be on the same claim as the G code. So make sure that you're not leaving any money on the table. Make sure that you're accounting for everything that happened, especially when you're using time to select that level of service. For inpatient and observation services, prolonged care code can be billed. If you're using time, it is billed using G0316. And again, you have to exceed the highest level of codes. Here, the codes we're talking about are going to be the 99223, which is 75 minutes, and that's that initial code, and 99233, which is that subsequent code at 50 minutes. So you'll have to meet or exceed that 75 or 50-minute threshold on that same date of service. Now, you're using that G3016. There is one exception if you have same day admission and discharge. It is date of visit and up to 3 days after time that you can count there. So you need to look and see what the documentation supports. Next, we have nursing facility services, and you're using G0317, and you're exceeding the highest level for that 99306, which is 50 minutes. and 99310, which is going to be 45 minutes. But you'll see here that for the 306, you do have to exceed that 95-minute threshold. You have to get to the 95 minutes, and then for the subsequent, you have to get to 85 before you can bill for the prolonged care code, that G0317. Time here again is a little bit different as far as what you can count. You can count time from the day before, the date of service, or 3 days after. For home visits, remember we talked about travel time not counting to that home visit, but prolonged care codes are, a code is available for home visits, and it's going to be G0318. It has to meet or exceed that highest level of 99345, which is 75 minutes, and then 99350, which is 60 minutes. But if you look in the chart, you'll see that you are going to need to meet that 140 and that 110. But again, here you do have a little bit more leeway as far as when what time can be counted and when that can occur. It's up to 3 days before the date of service and 7 days after. So before I check in with questions, I do want to talk about documentation. Documentation is definitely a hot topic, and it is something that we see questions often, and a lot of our pre-submitted questions were simply asking for documentation requirements, not necessarily anything specific. So we're going to spend some time talking about documenting time. So most importantly, the documentation must clearly document the total of time spent on the encounter, spent on managing that patient's care. Remember that this is total time, so you want to make sure that you're including those face-to-face services that are actually happening in the visit, in the encounter, but also the non-face-to-face qualifying activities. So as we mentioned, it could be the morning before or the morning of the procedure or the encounter before you physically see the patient. You could be looking over their chart. You could be reviewing some tests. If that is happening and being done by the practitioner that's going to be performing the face-to-face time, that is something that can be counted. So again, don't undervalue the service, especially when you're deciding whether or not to use time versus MDM to determine that level of service. Sometimes a few minutes can make the difference of that level of code. Another example of those non-face-to-face activities, if there's independent interpretations that are not being billed separately, if there's any care coordination being done by the provider that's not being otherwise billed. Those are things that you want to, again, make sure that you're including so that you have a clear picture of what time was spent on that encounter. If you are going to be billing for prolonged care, so those G codes that we just discussed, Medicare is going to be looking for the reason for the prolonged care. So it needs to make sense when it's pulled for review. Why was there additional time? Why were there additional activities from what's typical for this particular encounter? Again, we're not asking for a novel in the documentation, but it has to make sense. It also needs to support the medical necessity. We talked about this at the beginning of today's session, and that medical necessity piece is the first determining factor in whether or not a service is going to be covered. So again, why are the services medically necessary for that patient in that encounter? Even though you're using time to select the code, Medicare still needs to see the proof of thought as to why services are needed. This is something that comes up often in our cert error reports where the documentation is not supporting the need for the service. Again, not a novel, but it does need to clearly explain why the services were needed, and it needs to make sense. One question that we got related to this was asking, does the physician need to list out all of the services provided at the E&M visit in order to bill for time, or can they simply document how much time was spent on that day? This is a fantastic question. So, as I said, we're not looking for a novel, and they don't have to list every specific service to bill using time. However, again, it has to be clear what was done for the patient. So, simply stating the time that was spent, 15 minutes spent with patient on the summary, that's not going to be sufficient to support the service. You need to justify the time that was spent. So things to look at is summarizing what happened in that encounter so that reviewers understand why this service was medically necessary. So what does Medicare expect? An accurate reflection of that time, as I've been saying. You want to avoid things like ranges of time. I just said, spent 15 minutes with the patient. It's not a range, but that's insufficient. A range would be 30 to 60 minutes. It's not something that's going to be acceptable because, with some of those codes, 30 to 60, somewhere in the middle there is going to be a different level of service that you're going to choose. And you need to meet or exceed the time thresholds for that level of service. So statements that include that range, statements that are kind of less than statements. This is going back to older documentation, but we've seen it. Statements where you say less than 60 minutes, that's also not acceptable. Again, we're not looking for the providers or your office to stopwatch what's happening, but it has to be an accurate reflection of the provider's time. Give us that time. And again, including that total time spent, services that were performed face to face and non face to face, things that are directly related to managing that patient's care. So here are some of the things that we discussed today, some of the resources that we talked about. I have included a link to that evaluation and management services booklet. I'm just going to go back out there. I have the link for you. This is going to be very beneficial to you. It's going to include these charts. Here's the office and outpatients. If you continue to scroll down, you will actually see a larger chart. What is in your presentation today is going to be screenshots of smaller portions of the chart, but it does talk through all of the different services and all of those time frames and thresholds for counting that time that we talked about today. So that's going to be something that you want to take a look at. Also included a link to the Chapter 12, so that claims processing manual, and then a couple of other resources that we have on our website that will help you with documenting that time for your medical records. Let me take you out to that. This is on our website. Now I use the link, but if you were to come out to our website, oh, wrong one, sorry. I tend to search, use that global search. I started typing in documenting time in the medical records. That will get you to the same place. We do also, or excuse me, let me stop there. Here it will talk about a couple of things, not just specific to choosing level of service, but it'll talk about different scenarios for documenting your time. We did get a couple. I do have one that I'm going to be addressing here coming up in the question section, but this will be a valuable resource. We do have a resource for prolonged care that also provides some additional resources related to selecting prolonged care. And then we also have a resource for professional services and time. And again, I'm searching, but I have included the link for you. So here it is also talking about a little bit about counting those times and a lot of the things that we've talked about today. So those are going to be good resources for you. So that brings me to the question and answers section. Again, if you have questions, throw those in the chat. I've seen some come through, so I know some of you have maybe gotten responses from Ashley. But before I check in with Ashley for any questions that we want to discuss here today. I do have a couple of pre-submitted questions I'd like to go through. So the first question is asking about unique situations in shared visits, so split shared visits, with time indicated by the non-physician practitioner only due to discharge summary by same non-physician practitioner, but the recommendations and discharge summary state attesting is the they're the discharge provider, and further recommendations come from that provider. The physician documents more MDM, like we have listed on our shared visits website under unique situations, and they're asking if those unique situations still apply. So give me one moment. So this is the split shared services, and if you scroll down, I apologize for the scrolling, there's this section, and I'm going to zoom in so you can see that a little bit. They're asking about unique situations. The answer to that question is if these still apply, or that question is really asking if these still apply, and the answer is yes, they still apply in 2026. For split shared services, it's really about who performed the substantive portion of that visit, whether that's the greater than 50% of the time or the substantive portion of the medical decision making. So it would also apply to time. That is something, though, you're going to have to determine based on the documentation. If you have a split shared service and we're looking at time, both practitioners involved are going to have to document their time so that we know who did more than 50%. You could have a situation where there's time and MDM documented. You have to look at what the substantive portion of that encounter was, and they would be that billing provider for split shared. The next question that we have, this was one that came in right before the session started, so wanted to make sure that we caught that. The question is, can the critical care charges be billed on a UB04 form for the facility? And if so, can you explain the difference when to use those charges versus the ER charges? So the answer is yes, the critical care services can be billed on that UB. For critical care, you're going to need to make sure that the patient is meeting the requirements to be eligible for receiving critical care and that they're receiving those services. And again, we gave those links to those critical care encores for those webinars that we did late last year. Ashley, I don't mean to put you on the spot, but if you could throw those links back in the chat. If you want to look at the requirements for critical care, I would recommend taking a look at that. Now, when you're billing on the UB, you do need to make sure that you're using the appropriate revenue codes, which is the 068X for critical care, or those CPT codes, and then for ER, you want to use the 045X revenue codes. Second part of that question is the difference between when to use the critical care charges versus the ER charges. It's really going to depend on what services are being provided to the patient. Again, looking at what the requirements are for critical care services versus ER services and what that patient is receiving to determine whether or not those services are billed. And again, it's coming back to that documentation. So I do have just a little bit of time, so I'm going to check in with Ashley. Ashley, do we have any questions in the chat?
Hi, Leanne. We do not have any unanswered questions in the chat.
All right. Thank you for that, Ashley. Now, I do want to call out, if you think of a question, you get off this session, you think of something, happens to me all the time. Sure, it happens to others. I will be taking questions for the next 7 days. So if you have any questions, please feel free to submit those. You're going to send them to our education mailbox, and Ashley's going to throw that information in. Actually, thank you. You just did. Throw that information in the chat. That is our education mailbox, that same one that you used for technical issues. You're sending that to wps.gha.education@wpsic.com, and you want to make sure that you're putting the title of the event in the webinar. That's the New Growth Essentials of Time to Choose E&M Level of Service, Part 1 of 2. If you get Time to Choose E&M Level of Service, that will still get to Ashley and I so that we can answer those questions. But that subject line is pretty important in order to make sure that we get those. And then we will respond to those questions. Again, you have 7 days to get those to us. Now, in a couple of minutes, you're going to be receiving an email that's thanking you for attending. Don't delete that without taking a look at it. A couple of things here. It is one opportunity for you to provide us with some feedback on how we did for you today. Our ultimate goal is to provide you with excellent customer service. So you are going to be getting a link to a survey that Ashley's also placed in the chat. You can use that link. But tell us what we did well, what you want us to continue to do for you, what you want to continue seeing, what we could do better. And also there's a comment section that you could provide some additional information on how we can improve, including topics that you'd like to see in the future. So I want to thank you in advance for providing us with some feedback. This is something that we look at, and your feedback does drive everything that we do. And we want to make sure that we're supporting you. The other thing that is going to allow you to take the survey is going to be a pop-up box when you leave the session. It's not malicious, it's not spam, it's not taking you anywhere you don't want to go. It's just a redirect telling you that you're leaving our webinar software and going into CMS's Qualtrics survey software. Another thing to look in that email for is going to be continuing education credits. Some of you may be attending for continuing education units. We do not issue those credits. However, we do provide a certificate of achievement that can count towards those. And that email serves as your certificate, and you can submit that to your accreditation or certification body to count towards those. It'll have the title of the event and the contact hours, and they are recognized. If you didn't get that, one of two things happen. Either our WebEx Messenger that the sender is WebEx Messenger, and our WebEx Messenger email is not on your safe sender list, so consider adding that. So it might be in your junk or your spam folder. The other thing is that you attended via phone today, and I don't have a systematic way to confirm your attendance. That is okay. Using that same education mailbox, go ahead and send us a quick email and include the phone number from which you attended, and I will be able to confirm your attendance and get a certificate out for you. All right, so again, I want to thank you all for taking some time to provide us with a little bit of feedback. Remember, you have 7 days to go ahead and provide us with any questions that you come up with after the session. But on behalf of myself, Ashley, and Tom, and the entire Provider Outreach and Education team, I want to thank you for taking the time to attend today. We know everybody's really busy, and sometimes carving out an hour is a little bit of a feat. We look forward to your survey comments. We also look forward to seeing you on Ashley's session tomorrow. Registration is still available. That's that interactive session that's going to let you apply your knowledge from today. So you do have time to register if you've not done so, and certainly hope to see you there. With that, again, I would like to wish you all a great rest of your day. You may now get disconnect.